right, let's dive right into this explainer. Today, we're unpacking a really harsh reality about how a supposedly unavoidable medical emergency is, well, often a completely predictable outcome of systemic neglect in nursing homes. When families entrust long-term care facilities with their vulnerable loved ones, they expect basic, fundamental clinical vigilance. But as we're going to see, when that standard of care breaks down, the consequences are absolutely devastating. We're looking at the exact timeline of sepsis today and exploring how basic inaction can turn a totally manageable condition into a fatal crisis.
So, look at this. What do a simple UTI and multi-organ failure actually have in common? It's a pretty provocative question, right? But it gets straight to the heart of what we're analyzing today. What is the trajectory from a minor, localized infection to a fatal systemic crisis? It might seem like these two things are worlds apart, but in a long-term care setting, the bridge between them is often just a matter of hours, and it's built entirely on missed warning signs and delayed care.
First things first, we've got to absolutely shatter this myth that sepsis just strikes out of nowhere, like it's some freak, unavoidable accident. It's not. In reality, sepsis is a life-threatening downstream complication of an untreated infection. It is frequently the direct result of delayed recognition by overwhelmed facility staff who just fail to observe, document, or report the early, visible signs of an illness.
Let's take a look at the ticking clock of this clinical timeline to understand exactly how fast a critical window for intervention can slam shut when basic care is neglected. The source material breaks this down into three distinct, highly predictable phases of decline. We've got Phase 1, the initial 0 to 24 hours. Phase 2, moving into hours 24 through 48. And finally, Phase 3, hitting that critical 48 to 72-hour mark.
Okay, starting right at the beginning. Phase 1, the initial localized infection, happening in those first 0 to 24 hours.
During those first 24 hours, the infection is usually localized. It's contained to its source. This is your golden window for treatment with simple antibiotics. Where do these usually start in long-term care? Well, UTIs are huge, and they frequently stem from inadequate hygiene or poor catheter management. Then you have stage 3 and 4 bedsores, which happen when staff fail to reposition bedbound residents every couple of hours, letting dangerous bacteria colonize open wounds. Aspiration pneumonia is another big one that happens when rushed aids feed residents lying down, causing food to get into their lungs. And cellulitis? That often just starts from unclean skin tears.
Now, to catch these primary sources early, there is a very strict standard of care. We're talking routine skin checks, constant vital sign monitoring, and immediately notifying a doctor so lab cultures and antibiotics can get started. But, and here's where things go off the rails, when a severely understaffed facility misses these basic requirements, the early warning signs like a sudden drop in fluid intake or a foul odor are completely missed. Just like that, the golden window closes.
Which brings us to Phase 2, the systemic inflammatory response, hitting around hours 24 through 48.
Because that initial infection was ignored, toxins flood the bloodstream, and the immune system basically panics, releasing a massive amount of inflammatory chemicals called cytokines. To identify this hyperinflammatory state, medical pros use specific clinical checklists. They use the ULCers criteria, looking for weird temperature spikes, high heart rates, and high white blood cell counts. They also use the Q-SOFA tool, checking for altered mental status, low blood pressure, and rapid breathing. These are objective, screaming red flags. But in poorly run nursing homes, these vitals are frequently misinterpreted, or honestly, just entirely ignored.
Here's a really surprising medical fact you absolutely need to know. Older adults do not present with infections the same way younger people do. While a classic sepsis symptom is a high fever, elderly patients frequently do not spike a fever at all because their immune systems are just weaker. Instead, their main symptom is acute altered mental status. We're talking sudden confusion, intense lethargy, maybe even hallucinations. Sadly, untrained or rushed staff often wrongly dismiss this massive cognitive shift as, oh, it's just their dementia progressing. Actually, scratch that. It's a massive medical emergency.
And if those early signs are missed, we enter Phase 3, severe sepsis and septic shock, from 48 to 72 hours and beyond.
The stakes here? Absolutely life or death. By hour 48 to 72, this person desperately needs a 911 emergency transport and broad-spectrum IV antibiotics. Without it, the mortality rate skyrockets to between 30 and 50%, and for frail or elderly populations, it can run even higher. We aren't talking about a simple infection anymore. This is a literal fight for survival against massive systemic failure.
The clinical breakdown at this stage is frankly terrifying. Blood pressure drops dangerously low and won't respond to fluids. That's called refractory hypotension. Critical organs are starved of oxygen, so toxic lactic acid builds up in the blood. This leads to complete multi-organ dysfunction syndrome. Kidneys fail, causing a total stop in urine production, and you even see a condition called DIC, where widespread microvascular clotting can actually lead to internal bleeding or tissue gangrene. It's a complete cascade of failure.
So, how does it get this far? Let's go below the surface and look at the corporate root causes.
How does a completely treatable UTI escalate to organ failure? Listen, it almost always comes down to dangerous profit-driven practices happening behind closed doors. Have you ever heard of ghost staffing? It's when management cuts nursing hours to maximize profit margins, leaving one single nursing assistant to handle 20 to 30 residents. It's physically impossible. And to keep up with mandatory quotas, those overwhelmed workers resort to ghost charting. That's when they retroactively type perfectly normal vital signs into the system without ever actually checking the patient. It legally masks the understaffing and completely hides the escalating infection from families and doctors.
But the systemic strain goes even deeper than that. On top of sky-high turnover and relying on temp agency staff who literally don't know the residents' normal baselines, corporate profit motives can be shockingly brutal. Some organizational cultures actively discourage their staff from calling 911 for emergency transfers. Why on earth would they do that? Because hospital admissions mean the nursing home loses their daily bed occupancy revenue, and it can trigger unwanted state regulatory scrutiny. So they just keep the patient there as they decline.
Now, to actually hold facilities accountable for these massive operational breakdowns, state health inspectors use specific federal regulatory standards. They're known as F-tags. For example, they might hit a facility with an F-684 citation for a massive failure in quality of care, or an F-689 for failing to protect from accident hazards like ignoring a bedsore. There are also tags for delaying pharmacy services, meaning the antibiotics were late, or for severe facility-wide breaches in infection control.
So, where does this leave families? Let's talk about seeking justice and accountability. If a family suspects their loved one's sepsis was caused by these kinds of systemic failures, holding the facility accountable in court takes hard, irrefutable data. Attorneys dive incredibly deep. They use electronic medical record audit trails, literally pulling millisecond metadata to prove if vital signs were magically entered hours after a patient was already at the hospital. They use unvarnished ER triage notes to show exactly what kind of neglected state the resident was really in upon arrival. And they analyze federal payroll-based journal staffing records to mathematically prove beyond a doubt that the facility was running on unsafe ratios the days leading up to the crisis.
If you ever, God forbid, find yourself in this situation, there are immediate, actionable steps you have to take to preserve evidence. First, take clear photos of any physical signs of neglect, like bedsores or unwashed conditions. Second, request the full medical chart directly from the hospital ER. Third, file a formal complaint with your state's Department of Health right away. And fourth, consult an experienced attorney immediately. You need them to serve formal preservation letters before a facility conveniently alters their electronic records or throws out their staffing logs.
Which leaves us with one incredibly vital question to think about. When the clock starts ticking on an infection, will you recognize the hidden warning signs before systemic corporate neglect completely runs out the clock? I really hope this explainer empowers you to spot these systemic failures, understand the critical timeline of sepsis, and demand the absolute standard of care your loved ones truly deserve. Keep asking the tough questions and never stop looking beneath the surface.